The next thing that we would be wondering is what steps can one take to receive the best treatment? And if this is something that we talked about a little bit while you were gone, we talked about getting a good specialized mesothelioma team, but in addition to getting a specialized team, what other steps can one take?
That's a very good question. So I think today people are more educated, and the information is easily accessible on the internet. So I think patients need to search for centers that have been treated in mesothelioma, or centers that are engaged in a multi-modality, multi-specialty treatment. What do I mean by that? Well, I'll give a classic example. If you come to Chicago, for one reason or the other, it's not really surgically driven mesothelioma treatment. What I mean by that? Most of the academic centers will not be aggressive in the surgery end. Therefore, you're more inclined to get chemotherapy as probably the only therapy than if you were to another center in which you can get chemo, surgery, the chemo radiation following it. So patients need to say, okay, if there is a doctor in Maryland who has this trial and it sounds like a great idea, but he's not talking about anything else about the trial, I'll say, wait a minute, everybody's telling me that, and it's written in the literature and published, that the best therapy is multi-modality therapy, chemo, radiation, and surgery. If the best results are with combined therapy, why should I just go and get the latest and the sexiest therapy, and no one's talking about the other modalities of therapy? It's just because they don't have anything else? Just because there's other interests behind that trial? So I say this to patients, look for the best place to get treated, and that has to be a multi-modality center in which they offer you all the subspecialties.
Thank you. How about Ellie and Lisa? Any thoughts on that?
He's right. He's absolutely right. What, I guess, Dr. De Silva, what do you see about intraoperative chemo? Do you think that's the future totally, or what do you think?
You know, I don't think that's the future. That is the present.
Yeah.
In the future, we just acquired a mind-boggling intraoperative radiation therapy. So now we have a radiation machine that will open the chest or abdominal cavity, and we write in a protocol with our radiation oncologist. So we'll do the surgery, whatever we think it's too bulky or too invasive, question mark about the margins or whatever. We're going to bring the probe into the chest and just deliver local radiation. Never been done before. We're very excited with that. So,
is that a clinical trial?
Well, but then it's within a protocol. So what I'm saying is chemotherapy still is heated chemotherapy. For me, from my point of view, it still is the best result for what we call local control after surgery, not in place of surgery. In other words, if you open the chest, dump chemotherapy in there, don't take out the tumor, I'm afraid nothing's going to change. The heated chemotherapy is really to control what's left around that we can't see. Mm-hmm. And if there's question in margins or depth of penetration, because the chemotherapy has a depth in which it would stop working, not radiation. Radiation can bust through it. So maybe that the future will be intraoperative radiation. Maybe the future will be something different, immunotherapy. But as it stands now, the present, I think it's surgery, chemotherapy, and intraoperative chemotherapy.
Hmm. Now, the intraop radiation therapy, you do it intraop, do you follow it up later? Like
So the protocol is being written right now. And then again, we're very excited with this because we got the machine and we're going to start with lung, and then mesothelioma is going to be next to it. So we're writing two protocols, one for lung.
Wow.
So the whole idea is if you have lung cancer, but we really can't take cancer out, can we remove part of it and just buzz it with radiation? So when we wrote the protocol, I said, why can't we do this for mesothelioma? Has anyone done it for mesothelioma? And we looked up, and no one has done it. So we're very excited to be probably the first program to offer that. Now, that's just adjunct to everything else that we're going to be doing.
Yeah. Wow. So it's gone. I think one of the talking to patients and everything. One of the things I think a lot of people have the impression that it's cisplatinum and cisplatinum. That's chemotherapy.
Carboplatin,
Yeah.
right? Based.
Yeah.
So within a protocol, I mean, this cisplatin-based chemotherapy, we're just reviewing a book chapter that we wrote. It's coming out next year about that. So the cisplatin-based, it works good for everybody.
Mm-hmm.
So it's not ideal drug, but it's been time and time over and over again proven to be a safe drug, has good penetration, good killing of the cells. So what we've done is add different drugs to the cisplatin base. So the cisplatin will be the basement of your house, the foundation, because it really works across the border for cancer. Then on top of that foundation, built with different blocks of chemotherapy. So Genzar is one of them. Alimta is something that we're looking to doing intraop. No one is doing it. If you look at most of the research done in that area, really triple chemotherapy would be ideal. But the best results for cancer in general, across the border, whether it's GI, lung, mesothelioma, is with triplet therapy. So it would be carbon-based or carbotoxin-based chemotherapy, followed by 2 other drugs on top of it.
Wow.
Impressive.
So that's what we were saying. There's so much going on that you have to, you
Right.
have to give yourself a chance.
That's right. So, and there's immunotherapy, target therapy. I want to make a point that patients really, and patients advocates really need to understand that most of the trials, they are trials. They are not to be used in place of or to replace the current therapy that we know it works, which is chemo, surgery plus chemoradiation. Because if you start replacing, especially early stage disease, if you start replacing the multimodality therapy that we know works by a single trial, then you're setting yourself up for, I'm not going to be able to take this call, I guess. Someone from Boston's calling me. I wonder who that is.
Not me.
Imagine, I can't even pronounce his name because it's one of those foreign names. Anyway, so joking apart, all I'm saying is you shouldn't be lured into doing a trial. A trial. A patient should go to a trial after the standard of care has been applied to that patient. So a lot of patients come and ask questions. Well, I want to see you, but you said surgery, chemo, but Dr. X, Y, and Z in California has this new drug. It's a trial. I said, well, it's not the standard therapy. I would not suggest you do that. If you want to pursue that, it's fine. It's your life. It's your choice. As a physician, I really can't suggest that. You've got to go through the steps. If those treatments fail, which, as we all know, eventually they fail because there's disease progression and so forth and so on, then you go into a trial because there's nothing else. Now, if you go to a trial, you may have burned bridges. Now, the trial doctors are brilliant doctors, and they want to make sure that their trial works really well, and we support them. Of course, we have trials here too for lung cancer, not for meso at this point, but for lung cancer. And they put barriers in which to say if the patient gets X, Y, and Z, can't qualify for my trial. They almost want to replace everything else for the trial. I think the trial is reserved for those patients in which multimodality therapy is not really indicated, or the multimodality therapy has been applied and failed, and you're looking at early recurrence. And then, yes, I think you should go into a trial.